to go ahead and introduce myself first. My name is Matt Stahl. I am the Clinical Marketing and Brand Director at EloQuest Healthcare. So I'm the Brand Director for SecurAcath. And I am joined by my colleague, Laura Crick, who is with Interad Medical, the manufacturer of SecurAcath. And so we're going to be here chiming in, and we might even get some input from our good friend and colleague, Steve Wilson, as well. But without any further ado, let me go ahead and introduce Sasha Harris. Sasha has been a second career nurse for over 15 years. She began her nursing journey as a CNL in the pediatric ICU before transitioning into vascular access at a world-renowned hospital in Maryland. Her experience in vascular access includes adults, pediatric and neonatal patients, and eventually leadership as the unit manager. Through her leadership, Sasha has worked to integrate the adult, oncology, and pediatric teams, cross-training staff to provide more flexible and responsible service hospital-wide. She expanded night shift pediatric coverage, pediatric PIC service hours, and established a team of CLABSI prevention coaches, adding over 5 full-time employees to the department. In March of 24, Sasha moved to Northern California, where she serves as the subject matter expert and program manager for vascular access at one of the top pediatric hospitals in the country. In this role, she supports best practices and promotes excellence in the care of patients with vascular access devices. Sasha is also in the process of earning her postmaster's certificate as a pediatric clinical nurse specialist. Sasha is mom to 2 amazing adult kids, 2 fur babies, and has been married 31 years to her husband, Tom. She never turns down a game night, loves to travel, and has recently taken up... What have you taken up recently, Sasha? I missed it.
Crochet.
Crocheting, okay.
Yeah.
Wonderful. Well, Sasha, welcome to this virtual drop-in training session for SecurAcath. We're happy to have you here. As you can tell, it's 4 o'clock in the Eastern time zone, so my tongue's getting a little tied, so best to hand it off to you.
Let's say you don't have your afternoon coffee like me.
I started brewing it, right? But I never got to drink it.
Thank you, Matt, for that introduction. When I sent you that, I didn't know you would be reading it in front of me, in front of everybody. It makes me uncomfortable to hear those things, but no, I really do love the work that I do, and I've been very lucky to be a part of 2 really amazing teams, vascular access teams, and continuing that work here with expanding my education to the CNS role. Which really aligns with everything that I'm doing now. But just happy to be here as well, just talking about SecurAcath and my experience with it. To kind of start things off, I'd like to know what some of your experiences are with SecurAcath, if you're using it already, if you're not using it. And I think we have a poll, right, that we can start talking about. It's the first one, Laura, I think.
So I closed the getting to know you one, but I can post the other one. Yep, got it.
Okay.
The confidence.
So the getting to know you, does that have who is using SecurAcath and who is not?
Yes. Yeah.
Okay.
And
so for those of you who are using it or thinking of using it, this is a good assessment too, to kind of see where you are with the product. I love to see people extremely confident. Yeah. Some people who are newer to it, not confident. That's great. This is really good feedback.
Mm-hmm.
Okay.
That's
So
it.
good. Yeah. Just like a mix, right? A mix of people. For those of you who are not confident, if you feel comfortable sharing what some of those misconceptions or things that make you uncomfortable about the device are.
I can share from when I've been in the field training. I think one of the things I see folks struggle on with insertion is the dexterity or the hand positioning. So holding traction on the skin while directing the toes into the position properly. Any feedback on that?
Yeah, actually a great start with inserters. So those of you who are inserting or, getting ready to or thinking about using it, it is something that you have to learn how to do. And the way that the product is designed, it makes it kind of easy if you know how to do it. So I can start with the demonstration, like this big model here. Some people don't understand exactly how the design is intended to go easily into. This is a giant SecurAcath. They don't actually come this big for patients, so this would be kind of intimidating to try and put in. But it happens after your line is in, and it goes right here into where your insertion site for your catheter would be. And when you fold it becomes like an L shape here. Which is perfectly designed to just insert into that insertion site right next to where your catheter is coming out. And most people just try to get these prongs in and then open it. But that's not enough depth for the catheter to really be fully secure and comfortable for the patient, really. So one of the things that I kind of learned over time was when I was struggling, it was because after I made that turn, I was just releasing it, but you really should go in and push the device in so it gets into those deeper layers of the dermis so that it's fully seated underneath the skin. And once you get it in there, then you can open it up and it really just kind of sits in there without a lot of difficulty. Well, sometimes you'll see like the little prongs might be crisscrossed here. That means that you didn't get it deep enough, so you should try again. So when that happens, I usually just fold it up and just go in again and push down a little deeper before I release those wings, and that usually resolves the issue. But as far as like the device, like positioning for the device, you can see that this is a I guess a typical PIC catheter. This could be a tunnel line as well. The device itself is 3 centimeters long. So when you put in a SecurAcath, you have to make sure that you have at least 3 centimeters of catheter available. But really, you want a little bit more than that. So typically, I would plan for 5 centimeters external because it allows you to make a nice like little loop. And when you're inserting the device with the PIC already in, I usually leave the stylet inside the catheter. The stylet, or the guide wire, some people call it a guide wire, but the stiffening wire that's in your line at the time of insertion, it provides a little bit of structure and support to the opening to the skin. And it allows that SecurAcath to go in much easier. When I first started using SecurAcath, I would get my PIC in, and then I'd be like, okay, do I need an x-ray? And then I would take the stylet out and then put the SecurAcath in at the very end. And I really struggled because the catheter is really soft. And it doesn't really, it doesn't make it easy to get past it because it's so soft, it would just be pushing it aside. So I usually leave the stylet in it. And this catheter doesn't have a stylet in it. But I'm going to kind of demonstrate the way that the device is designed. It has this channel. So usually you get your PIC in, and I'm actually going to remove this to show you. I'm doing this from a seated position here. So once your catheter is in, I usually fold it up away from where I am putting the SecurAcath in so that it's out of the way. And then I'll fold it in half so you can see the little L shape there. And then holding pressure on the catheter here, you just kind of put it in, fold up, and then push down and release it. And And then once that happens, you can make sure that it's pulled out and laying flat, and putting the catheter in over this channel is really important because that makes sure that you're not flipping the top over the catheter, which can cause it to occlude. But really that movement of like having the catheter out of the way, having the wire in there, and then going in and down before you release, so you can pull it out and it'll be underneath the skin.
I think two of the key things I heard you say that I also include in my training is the stylet in. I find that that's twofold. One, it takes the smaller or flimsier catheters and makes them a little stiffer as you're creating like a little spacing there as you put the device in. And the second bit of advice is I find it to be like a safety check. So after you close the lid, when you pull the stylet out, you know that everything's properly aligned in that channel. So those dots are properly upright and those wings are in the same plane. So I think that that's really, really critical for success of the device in the long run.
Absolutely. And one of the protocols, so I'm going to finish putting this on and I'm going to show you the next step. So
yep.
Laura, you already kind of spoke to the making sure the markings of the catheter are facing up. That's important because if you don't do that and you twist it, then your hub is not going to lay flat on the skin, or it might twist, which could be a problem. So when you align the catheter in this blue channel, you want to see the dots facing up because that lines up with this suture wing or hub. Some people call it a hub. And that'll allow the catheter to lay flat and not kink or, cause the patient any kind of discomfort. It'll function better with the SecurAcath. So it actually has a little word here that says hold. And that's just instructions for the user to hold it there. Because if you do that, if you kind of follow those instructions, it will be easier to apply the top. So whenever I put the top on, you can hear the click. If you don't hear the click, you might not have it well seated. But the other thing I do is I'm going to kind of show you here. I always look to make sure that it's fully closed and inside that blue channel. But this is the first prevention for any potential issue, right? So yeah, there should be a screen side by side. That would be good. Oh, there is. We can do it side by side.
Is
that what you're saying?
Yeah, no, you're fine, Sasha. Don't worry. I was just answering the chat. I think that if you have more than one window open, I have one window. So whoever's speaking pops up in that window. So as you're speaking, you're popping up in that window, but the second window should have a side by side where your hands are in one screen and your face is in the other. So hopefully that can be corrected.
Yeah, just let me know if you need to see a different angle. I can move this pad to make sure that you can see, but this is kind of the angle that I look at the device after I put it in to make sure that it is in there. If you don't do that, it could be either one, you've clamped over the catheter inside. It's not in the channel. And two, it's not well secured. You don't want to see it open like that because that won't actually keep your catheter from getting pulled out. It might cause some movement. On the next dressing change, it'll be dislodged potentially. So this is always a check after it's in. And then we have a protocol to check for blood return right after you've removed your stylet. So, you verbalize that the SecurAcath is in place and that you've checked that you have good blood return after SecurAcath placement, which is just another reminder for the inserter to make sure that they've placed it correctly. And then the reason, that those 5 centimeters is, again, if you're making this turn, you can lay that dressing pretty easily. And I actually have dressing here to kind of demonstrate. You're going to want to make sure that this is still under your dressing because the catheter, some people ask me, can I just put the dressing on like this? No, you can't, because the catheter is not designed to bear any kind of weight of tubing that might be attached to the line, and it could cause the line to either break, or I've seen twisting, and suddenly they have a line occlusion. They don't understand why it's occluded, and it's because that's twisted. This is a single lumen, that's less likely, but with double lumen or triple lumen PICCs, that can happen pretty easily. So always make sure that you follow your facility protocol, and that the dressing covers the entire thing, and not just the SecurAcath. Okay.
As a general reminder, audience, if you have a particular question that you'd like to have answered, if there's something that's causing you to not have confidence, share your concerns in the chat. You can post them directly to me if you don't want everyone to see it, or you could post them to the group, and I can read your comments to Sasha so she can provide some guidance. And I think there was one post that just said it's new to their facility, so they haven't done it themselves. They haven't seen it done yet.
Okay, yeah. Well, I just demonstrated the insertion, but I kind of want to talk about some of the management pieces of this device, because that's sometimes where we see people, developing opinions about it without really understanding how to safely manage it. It's not difficult. One of the best things that I hear from nurses who are managing lines with SecurAcath, where they typically would use an adhesive catheter locking system to secure the device, is it makes this dressing so much easier and less stressful, because you know that line is not going to move while you're cleaning the device. And the other thing is, with an alternative securement device like an adhesive catheter lock, nurses are hesitant to really lift up and clean underneath here, because they think if I lift this up, this catheter is going to, either piston, or I'm going to pull it out, which we know is not good. We don't want the catheter to move while it's in the patient, really, unless we intend to withdraw it. But it makes it easy, because it's locked in there. It's not going anywhere. And it's not going to prevent somebody from yanking their pick out. You can pull it out if you really try, but with gentle movement while you're cleaning, you can really get up close and personal on that insertion site. So that's one, that's you're able to do that, but it's also important to do that when you're doing sort of routine maintenance on the line, because if you just let it sit in one place, then the body will develop fibrous tissue, scar tissue around anything that is foreign, and lifting it up like this really keeps those fibrous tissues from developing and sort of sealing that device in a position that might be uncomfortable. So every time you do a dressing change, you really should be lifting it up to 90 degrees. If I can show you with this, lifting it like this is just like on a hinge. It's not going to hurt the patient. There's not that much movement happening here. You're seeing it out here on this big thing, but not underneath the skin. It's really just like moving on a hinge. So it's perfectly safe and should not be uncomfortable for the patient. If the patient has had their SecurAcath in for weeks and weeks and weeks, and nobody has done this, it might be a little uncomfortable at first, but then it might break up that tissue that formed because nobody was lifting it up. So it's really important to do that with each dressing change. And then second, I said you can do this, right? That's not going to hurt the patient. But if you're yanking it around this way, you can see those little prongs, they're moving underneath. That will be uncomfortable for a patient. So for those of you who are managing the SecurAcath device after it's in, just remember that it should stay in the position that it was placed, oriented on the patient, but then it needs to be lifted up with each dressing change. Okay, so is it painful? No, it really shouldn't be. If it's well maintained, it should not be painful. The other thing I hear a lot is, oh, that's going to hurt when I take it out, like it's going to hurt the patient when I remove it. But really, if you understand how the device is inside the skin, then being confident with removing it can avoid any kind of discomfort. I work with a lot of kids. Usually they hate the dressing being removed more than the actual SecurAcath. They get upset before you even start touching the SecurAcath. So doing it quickly and confidently is the best way to avoid any kind of like association with the device, especially for children.
I think that's a great point that you bring up on the lifting and the scrubbing at the insertion site. I always mention the analogy. It's like when you first get your ears pierced, they tell you to rotate the earring so that the site around the earring heals properly. It's similar to that in that you want the tissue to heal around it and close appropriately. But if you don't move it at all, it gets super tight and it's very uncomfortable when you go to rotate it for the first time. So if you rotate it a little bit every day, or in this case, you lift it at every 7-day dressing change, you're going to have the appropriate amount of tissue healing and not have it overgrow.
Yeah, exactly. That's a great analogy, actually, the earrings. We wouldn't just not pierce, ears because we have to rotate them. You pierce your ears because you want it pierced, you like it. And then you just have to know how to care for it.
Yep, absolutely. There's a question that was posted. And how is SecurAcath in comparison to cyanoacrylate glue? I'm going to just maybe enhance that question specifically in terms of retention of the catheter for the intended use of that particular catheter in your experience.
Yeah, well, I'll tell you that. So the glue, it has to seal properly or it won't hold the catheter. It's a great tool, especially for those catheters that are too small for a device like this. The neonatal population, or if you don't have enough external catheter to position the line in a SecurAcath, if you have less, than the 3 centimeters external, the glue is great, but you do have to know how to apply it. Excessive application can cause, crusting on the catheter and leave debris on the skin or residue. And if you don't allow it to cure properly, it's not going to seal. You can break that seal pretty easily. So our facility actually uses the glue with the SecurAcath because we use the glue more for, a barrier at the insertion site. But it's great when you're taking the dressing off, but once that dressing is off and you've cleaned it, that glue is not on there, you can still, the catheter can still move in and out. Whereas with the SecurAcath, it's just not going to move. So before, during, and after cleaning, you can sort of feel secure that the device is going to keep your line safely in position.
And I think
your
points there are also evidence-based. So the SIC and SIP protocols all call for the combination of the two, one for the site sealant in SecurAcath for holding the catheter from the beginning of placement to the end of use. And then, there's a great study that shows that with the SecurAcath, catheters can get to the end of therapy greater than 98% of the time. So if anybody's looking for evidence to support their interests, we have a library of evidence and we're happy to share that with you. I'll post a link in the chat shortly. But if you have other questions, we're interested in getting your curiosities, your questions, your concerns. Feel free to unmute if you're brave and want to speak, and you can ask your question yourself. Sasha's here to answer your questions and make everyone feel warm and fuzzy and have your questions answered by somebody who's been using the device a long time. So how long again? Did Matt say that? How long have you been using SecurAcath?
It's like 2017, I think. 2017 is when it was implemented in the adult population at my previous institution.
Awesome. And then since you changed hospitals in that time frame, you're seeing it even in the hospital that you're working in now?
Yeah, we're using it. We're using it here as well. We're trying to expand it to some other catheters. With people really using it and getting that experience with it, we're able to kind of expand the patients that can benefit from it. So we're currently looking at piloting SecurAcath with some tunneled catheters in our current hospital. So we're trying to expand on this product that we know works really well on all vascular access devices.
That's fantastic. And I think uh, it's at your former institution, it's being used both on PICC lines, midlines, central lines, at tunneled catheters, and acute central lines. So it's a pretty broad base of use there.
Yeah, absolutely. And one of the populations that we're seeing a lot of benefit from SecurAcath is in the cardiac infant population. A lot of those patients have PICC lines. A lot of them are 2.6 French PICCs, just based on the size of their vessels and the patients. And we were successfully using it on 2.6 French PICCs at my last institution, and we're looking to kind of expand that at my current hospital as well, because we have kind of a similar population here.
That's great to hear. Great to hear. And I think, again, I think the big goal in vascular access is to try to minimize the number of catheters we expose our patients to and their demands. And cardiac patients that are born with cardiac congenital issues may need lines for a long period of time, if not most, or if not all of their lifetime, to support their needs. So it's good to hear that you're able to maintain lines for hopefully long periods of time.
Yeah.
In that nature, what is the longest that you know of that you've had a patient with a SecurAcath?
Well, in my previous institution, we had a patient who had a line for like 2 years with the SecurAcath, and it did go till the end of therapy. But in the interim, I've seen patients who have needed their line replaced because they outgrew it before they needed any kind of intervention with the SecurAcath. So that SecurAcath kept that line in position for months and months until they just needed a new line because they had outgrown with their previous line where it was placed.
I love those stories because before SecurAcath, I've heard tons of children needing lines replaced prematurely because the catheter migrated, moved, the tip became suboptimal, not because the child just grew out of it. So I'd rather see these kids get to the point where they're growing out of their lines than needing them replaced frequently.
Yeah, absolutely.
And I think for anybody who doesn't know, on our evidence, we have a case study actually out of the Baltimore area. The longest tunneled line was in for 5 years with one catheter. It was a non-cuff tunneled line in an elderly TPN patient. And they retained that catheter for 5 straight years without any complications, no infections, no replacements. So that to us is another really great example of longevity when access is needed. So helps with preventing all of those harms. Are there any other questions from the audience? I'm going to ask you to either post or come off mute. I'll give you a couple seconds. Go ahead, Sasha. Sorry, I didn't mean to cut you off.
I was just going to say that, that story about the 5-year line really, really hits home. We have a lot of the shortcut kids who really, they need their lines for their entire life. We've had to replace several of them in my current hospital because of complications due to sutures or, cuff exposure from dislodgement, either because the kids are, moving a lot or during dressing changes, because kids don't generally like dressing changes. So I love hearing that story about their tunneled line was in for 5 years, because some of our kids, their line is their lifeline. We have patients that just don't have the vasculature there anymore. They've used up so many veins because they've had to have lines replaced. So
time and time
thank
again.
you for sharing that.
Yeah, that's my favorite part about the product is I get all these great stories. And I know people who use it for a long time get them too. So it gives you that warm fuzzy when you've gotten the opportunity to see what kind of a personal and patient impact it can have.
Yeah, and I mean, on that note, I've had a couple of patients or patient populations, I'll say, because it was definitely more than one singular patient. We have in pediatric hospitals and even in the adult population, cystic fibrosis patients who have just long histories of getting admitted, needing a PICC line, getting their therapy, and then going. And that population, sometimes they tend to develop sensitivities or allergies to products that we're using to keep their line secure. So either the cleaning agent or the adhesive dressing that goes over the line. And, we've had patients with, especially in peds, epidermolysis bullosa, where their skin is just, you can't put adhesives on their skin. And we've been able to place a line in them and just use the SecurAcath to keep it in place with a gauze dressing that we change every 2 days. And that's been able to maintain the line safely without infection for those patients to give them the therapy that they need. And you just can't do that with adhesive catheter locks because their skin just rejects the adhesive. So it's been a good application for those patients.
I got a post in the direct chat to me, and the question is if you could touch on how you can minimize and or if pain is mentioned by a patient, assess and correct.
Yeah, that's a great call out. I'll say that sometimes if I've seen pain, it's because when the dressing was changed, and I'm going to kind of demonstrate on this model, they get this pushed in to their skin like that. And that can be uncomfortable because it's really pushing this plastic right up against the insertion site. So the first thing I would do is, clean it. If you have like some sterile saline, you can put that on there to kind of soften the tissue a little bit. And then just make sure that it's really fully engaged. So not pushed up against the skin like that, but make sure that those prongs are like pulled out to right underneath this. You're not going to pull it out when you do that, but making sure that it's not pushed up against the skin. That can be a source of pain. And usually that's induced by the person who is doing the dressing. So it's just a good thing for you as the person who's managing the line to make sure that that you're not doing that when you do the dressing, because that can be uncomfortable over time. The other thing is that, especially in infants, they tend to have like bony, like little divots in their skin because of their anatomy, which, their skin is not like level. It has like a little bend in it because of where their knee is or their ankle or their elbow. And some children's centers will put something underneath the device to kind of lift it up a little bit and be more parallel with that skin. And that can reduce discomfort with the device as well. If you have a line that's already in and you've tried those things, it might just be where the PICC is inserted. And, that might just need to be resolved without the device. But I've only really had to do that once, maybe twice in my history of using this device where the PICC was inserted like too close to a joint. And just a movement might cause a little discomfort because it is something that's under the skin, but sutures would cause that discomfort as well. And it just has to do with insertion practice. Otherwise, I would just make sure that, you've inspected the skin underneath to make sure that it's being cleaned and that it's dry before you lay the device back down. If there's any irritation, it could be that, the cleaning agent that was used just didn't get to dry long enough, and it caused irritation under the skin.
Absolutely. These are all good points. I think it always, for my education, I talk about assessing it with the dressing change. So if somebody is, and even before you take the dressing down, if the patient is an adult or able to articulate, obviously in pediatrics, you have to do a lot more intuitive assessments because some of your patients can't communicate or aren't going to help you understand why they're upset or irritated. But with adults, they can tell you like what kind of pain it is, if it's a sharp poking pain versus a burning sensation, versus it just hurts when I move. And sometimes doing a movement assessment and understanding like, is it an orientation thing? Was it turned during a dressing change that it's now like impinging in it and it's causing a discomfort? Or if it's too close to an area of flexion, as the patient moves their arm, you start to recognize that it's moving. It may need to be reoriented to address that kind of level of discomfort. I would always engage the vascular access team that inserted it if I'm a care and maintainer. If any of those signals are alerted to me as a person taking care of the line, and then I also just say the next step would be to just take the dressing down, because sometimes just the approach of the dressing can be too tight, can be pulling on it, can be changing the angle, as you indicated, like sometimes lifting the angle alleviates discomfort. If the dressing is applied too tight and it creates kind of a seesaw effect, the angles that are designed there are designed to lay in a certain position so that the base is on the skin and there's a seven degrees downward so that 2 millimeters of skin can sit there. But if it's getting pulled down, or the skin's fluffy, or there's some fluid shift in the patient, that can all create tension on the dressing, which can create tension on the device, which can trigger discomfort. All of those can be alleviated with a dressing change and addressing it.
Yeah, absolutely. I always say if there's any issue with either pain or the catheter function, look for mechanical issues first before we implement any additional intervention. So that would be a mechanical issue, right? The dressing is too tight. Maybe it wasn't positioned right. I've also seen trying to put an adhesive lock on the device in addition to the SecurAcath, thinking that it needed that. And then because this is fixing the catheter in position, when the patient moves, it actually pushes against SecurAcath, causing discomfort. And so just sort of understanding you don't need this extra securement down here, that this is going to hold your line in place, resolve the issue.
All great. Audience, I'm going to tap you again. Any other questions? Please feel free to send them either directly to me or post them in the chat, or come off mute and ask them yourself. We want this to be valuable for you and addressing your questions and concerns. In the interim, maybe you could show us how to successfully remove the device.
Yeah, sure. I'm actually going to stand up because I'm seated. So again, if you look here, it says lift here and hold here, and that's exactly how you take the top off. There's two ways to remove it, one with the catheter in and one with the catheter out. I like to remove it with the catheter in. That way, when I'm removing the catheter, I can really inspect the catheter and make sure the entire line is out, which is the standard of practice for removing any central device. But you really hold here and lift here, and it just pops the top off, comes off very easily. And then moving the catheter out of the way. I usually take one finger and use it like a hinge to kind of help it bend. And so I'll lift it up first, so that way the angle is, the hinge of the catheter is like this. And I'm not trying to open it or fold it with these prongs going into the skin. So I lift it up like this, and I use my thumb to kind of lever it. And then once I have a hold of it, it comes off very easily. It just slips right out. So I'll show that again. Once it's up, I use my thumb or a finger and then it just slips right out. And one of the misconceptions about this is that this is going to hurt the patient and that it's sharp, but it's actually really flexible and pliable. So it should come right out. If you experience any difficulty, actually, it was just a standard practice. The first time I tried to remove a SecurAcath, I didn't have a lot of confidence, and it was hurting the patient, and I didn't understand why it wasn't coming out. And then I talked to a SecurAcath representative who said that if there's any kind of tissue adhesion underneath the skin from, management of the line, or just the fact that it's been there, just putting some saline, soaking the site in saline before you even try to remove it, just softens that skin enough that it just comes right out. And I never had a problem after that. The other way is that if the patient is really saying that this hurts and they want you to stop, it might be technique for removal, but it might be that there is some scar tissue there that it just needs to be removed in a different way. And the other method is, I'm going to kind of show on this a little bit, is that you can so if you do it this way, you should remove your catheter first. So you would take your catheter out and hold pressure until you achieve hemostasis. You can even hold a gauze there. And then you take a pair of scissors and you really don't even have to cut all the way up. You just cut right here, and it starts to separate the channel for you. And that way, when it comes out, it's just one little slip, and then the other one slips right out. And that alleviates any issue with removal. But honestly, I haven't had to do that ever. I really haven't, and I haven't had any problems removing a SecurAcath, and I've removed a lot of them, and a lot of them on children who will tell you with no hesitation that they don't like you. Yeah, it just comes out really easy if you know to lift it up and bend it in half like this. Let's see if we can. And it really just slips right out the insertion site and comes out like that.
I think with what you're doing, and you do it probably very subconsciously, but I teach it with the intention, is that counter traction with the opposite hand. So no matter which hand you grab the device with and fold it, you really need to make sure that that other hand is holding that counter tension. So it's either holding the catheter and the skin, or it's holding the skin because you've pulled the catheter out. In either case, catheter in or catheter out, you still want to hold the skin taut as you pull the base out, so that you don't lift the skin with it. I think that often people think it's stuck, or there's a movement that occurs where the feet get turned the wrong way, and it's really important to keep that blue portion parallel to the skin so that those toes are pointing down in that insertion site, so that counter traction is effective at pulling the feet through that insertion site. So you showed it beautifully. I just wanted to highlight that your other hand was working almost as hard as your hand holding the device.
Yeah. And it's more natural when the catheter is there as well. Like you're already kind of holding down because you're holding the catheter in to create that tension. Yeah.
Any questions or any comments about removal? Any curiosities that we didn't address? It's an open session. We want to make sure people feel comfortable asking questions. Feel free to, if you don't want to post publicly in the chat, you're more than welcome to direct message me in the chat. If I will read your question anonymously. There are no silly questions. All of these are good questions.
I've had questions about using like an antimicrobial disc with the device. Like, can you put a disc on top of it? Yes, you can. You can also, because you don't have to worry about the catheter coming out when you take your dressing off, you can use it underneath. So that I don't have one with me today, but it has a slit in the device, and you can actually slip it right underneath the SecurAcath, and that also creates a little pad for the skin if you have patients who are prone to pressure, any kind of pressure injury. this doesn't inherently cause a pressure injury, but if those patients are at higher risk, then that's a good way to counteract any potential problems with it. And then we also, in my previous institution, used the CHG gel dressings. And they didn't used to, but now they do provide, there's like a smaller gel pad that is actually for ports. And we actually used it on our SecurAcath patients as well, because if you're using a gel dressing, it's just touching the top here. It's not getting to anything underneath the catheter. And even with a catheter that is not secured with the SecurAcath, if it's with an adhesive catheter lock, you still can't get that gel right under here, where underneath the line, basically exiting the skin. But if you're using the antimicrobial disc or the gel pad, you can slip it. Yeah, that's exactly
This
it.
is the one. If
That's
anybody,
exactly it.
this is what Sasha's referring to. I'm going to put it in front of my face because I have blur on, but this one works great. I've seen this, and a lot more sites are starting. If they're using the CHG, they're moving to this version because it goes all the way around, and the gel itself acts like a little pad, which is lovely. So nice combination.
Yeah. So, it really allows you to even get better protection no matter what microbial product you're using at the insertion site.
Agree completely. I love the discs, anything. And you can use it with hemostatic powders. So if you have a highly anticoagulated patient or a patient, that has issues, with site drainage, you can use, again, different agents. All of them are compatible with the device. There's no issues.
Yeah. At a conference recently, I kind of cornered the company that makes one of the hemostatic powders, because we had developed a way to kind of cut a keyhole in the foam topper that comes with the hemostatic agent. And we were wanting them to put perforations in that foam disc so that we could not have to cut it. But, because we use SecurAcath so much and we were so committed to continuing use, we wanted to make sure that patients who had other needs, they weren't precluded from having those products, like the hemostatic agent, really work at the insertion site.
Absolutely. Yeah, it's important to know what you're using, and when if and when you trial or implement SecurAcath, that your rep and your support team know what you're doing and what your variations are, so that we can help tie those products together and make sure that you're using them collectively most effectively. So we like to make sure we know what we're recommending and what you're doing, and minimize the impact of any connecting elements. I'm not seeing any other questions. I think you're doing a great job because everybody doesn't have a question. I'm just joking. But if you have a question, I beg of you, please come off mute. Feel free to ask. Post it in the chat. Post it directly to me in the chat. All of these options are available to you. You should be able to click your unmute button if you want to jump on and just ask your question directly to Sasha. But this has been fantastic so far. I've gotten all my questions answered. Let me think of another one for you.
While you're thinking, I'm just going to do a little plug, because one of the best things about this product is the support that clinicians and families get from the materials available. So go to their website. There are videos of every scenario on there, for inserters, for maintenance, for removing. There's an app also that you can, if you have a patient who's discharging with this catheter securement device, then you can encourage them to download the app. There's research on the website that you can share. I recently did that with one of our providers who didn't know a lot about SecurAcath. There's a randomized controlled trial right now that's been published using this device in comparison to other securement methods. It's just, one of the things that I think early on we were seeing is for people who don't know about the device, they were going into their doctor's office to get their PICC line removed, and the doctor didn't know what to do with it. So we just started handing cards out to our patients and informing them that, that there's an 800 hotline for this purpose, and a website where they can get information about it to, make it more transparent how effective and easy it is to remove it. So I encourage you to go to the website
and download the app. I appreciate you mentioning that. It's my favorite tool because the app has, direct access to us online and videos. I'm sorry, my lighting is bad. There we go. But you can see there's links to the videos, and there's a phone icon. If I can get my blur to stop. There's a phone icon on the bottom. When you tap that, it dials right to the hotline. So you don't have to know the 800 number. You have it right on your phone. You can even recommend, I know an institution out in that Baltimore area used to have patients actually download the app. So when they handed them the patient tools, they would suggest the patient download the app in case they lost the pamphlet. And the patients had that available to them to share with their providers or their caregivers that were outside of the institution. So it's a great tool, great resource. And again, even if patients call the hotline directly, we will engage with their care providers that may be either their home care or their community care providers, and make sure that the education encompasses that patient, because we do care. We want to see the patients have the best possible outcomes. So thank you for that plug. I appreciate it.
Yep.
I would also ask you, in terms of, patient populations, do you think there's any limit to which devices you in the future see your institution applying SecurAcath?
I mean, the only limit I can see is the available sizes of the SecurAcath. We do put in catheters that are smaller than 2.6 French PICCs, and they are a challenge to secure. Even some of the other securement devices out there don't fit on the lines to secure them. So we're finding these alternative methods. So really the size of the device is the limiting factor. Yeah.
There is a question that got posted. Thank you. The question is, can this be removed in the home?
Absolutely. Yeah, absolutely. Not by the patient. I would have a nurse, remove it. Obviously, they're
on
not
indication when it's appropriate.
Yep, appropriately. But yes, absolutely. It's like I said, it's really easy. So if the patient is getting their PICC line removed at home by the home care nurse, the home care nurse can definitely remove it. That was something that we would tell our patients as we sent them away. If your home care nurse comes and they see this and they don't know what it is, please have them look it up before they change your dressing. So the patients can advocate for themselves as well, which they should do in any case, not, regardless of what's securing their line in or what products are being used. But, we really wanted to make sure our patients were informed. But yes, it can be removed by any home care nurse that is caring for their line.
Absolutely. I think he's still online. He might not be. I can't see everybody's name, but Steve and I answer the hotline. Steve answers it more than I do these days. But if a home care nurse knows they have a patient, has never seen the SecurAcath, they can contact us even minutes before. There you are, Steve. We can coordinate training, and the training can take as little as 15 minutes. It is not difficult to train someone, and we can even be on the call while they're removing it if it's their first time as that virtual support. So we have the capabilities to do HIPAA compliant video calls and video conferencing and support those removals even in the home setting. And I can tell you we have we have calls that come in, and often it's a nurse who's never seen it or removed it before. And we have 100% success rate. If for any reason somebody does not answer the line when you call, if you need support, please leave a voicemail message and we will call back. We commit to calling back within 2 hours, but I will tell you our current average is less than 20 minutes. So we take all of the calls that come into the hotline quite seriously. So do leave your name and number and a number to call back, and we will call you back as quickly as we possibly can. But yes, we answer that hotline, and we take the opportunity to train seriously too. So do call it if you want to coordinate training for yourself, your team, an extended team, maybe a particular agency in your area. Maybe you're putting the lines in and sending the patients out. This is a great way for us to make sure that you're getting the clinical support you need outside of your own domain. So we want to make sure that folks know what a SecurAcath is and how to use it. We hold these programs routinely with our customers that are using the product effectively, and we will continue to do this. Sasha, thank you for this great session. I know we're coming up on the last couple minutes, so I'm going to ask everybody, if they have a question, please post it, and I will be happy to ask it for you. And if you don't, I'm going to say that we will host another one of these in the first quarter next year. Steve hosts a general in-service, a specific how-to in-service on SecurAcath every month. And if you need information on how to register for those or want to share information on those programs, you can find it on our education page, which I will post in our chat here in 1 second. Just need the site to come up so I can copy and paste. But there is registration for those virtual in-services, and we do post them every month, so you can join or suggest that. And if any of those days and times don't work for you or your team, and you want to have a training that's more specific to your institution's needs, we are happy to schedule those. There's an option for that. It says schedule a virtual in-service here, and it opens up a calendar, and you can pick the day and time that works best for you, and Steve or I will join you virtually to support those interests. So again, any other questions? I welcome you to come off mute, post in the chat. I feel like I'm a broken record with that, but we want you all to have your questions answered. Okay. We got to hang in here for 4 more minutes, but if anybody has a question, I'm gonna ask in general. Have you ever had a situation where you felt that the SecurAcath was like a solution, like the one patient where the light bulb went off for you when you said, "Oh my God, I get it now"?
I mean, any dislodgement. I mean, dislodgement is the worst possible scenario, especially in kids, because many of them require sedation or procedural areas to get their lines replaced. Yeah, we had a patient who, the PICC line was placed at the bedside using a procedure team for sedation. The sedation was very difficult to manage. They were trying to limit it. We used to call it like riding the Bronco, because like you're really trying to get your procedure done while the patient is like coming out of sedation. The nurse was, it was a new PICC nurse, and she was a little hesitant with the SecurAcath and kind of aborted putting it in. And she had like 7 centimeters external. The patient was managed successfully without it while they were here, but then when they went home, the line got pushed in 4.5 centimeters, and they were readmitted with this deep line. And that really just kind of cemented that the SecurAcath would have prevented that. Would have prevented infection. The line needed to be replaced. Yeah, just knowing that the line is going to be where you left it, and it can be managed safely by, people outside of your hospital or outside of your vascular access team, to me was just sort of a game changer for these kids.
Yeah, absolutely. I mean, and not every hospital has vascular access teams who can do dressing changes. And as somebody who runs around and educates those nurses, those, floor nurses that are doing those dressing changes, I can see the anxiety relief on their face anytime I show them, like, hey, you don't have to deal with the adhesive device anymore. This goes away. This is what your hospital's going toward. And they are so great. They're like, I don't have to change it. I'm like, nope, you just have to lift it and clean it. And they're so relieved because I'm sure that they've had that moment where it pulled back out or they accidentally moved it in. And if that movement happens, that's like, it makes me gag every time I think about it.
Yeah. The anxiety factor is a big one. Just when you're doing that dressing change, when we started using them on the 2.6 French picks, it was like a big sigh of relief for all of those, even the VAT nurses having to manage the dressings. A lot of them had to be like PRN dressings because they're sweating and the dressing is not adhering well. And so, those patients sometimes require more than one dressing a week. And it was anxiety provoking to try and make sure that that line didn't move while they were doing the dressing change. So when we started using SecurAcath, it was like a collective sigh of relief that we were going to be able to keep these lines in patients.
We got a thank you posted. They're jumping off to go do a pick line, and we appreciate you joining us for as long as you could. But they're using it 95% of the time on their picks, and they think it works very nicely. So they said it was a good refresher and great tips. So
Great.
Thank you, Sasha.
Awesome. Well, thank you everybody for joining. I really appreciate you taking the time.
Yes.
And, I hope your questions were answered about using and maintaining the device.
Yeah, absolutely. And if you did have questions and you weren't brave enough to post or comment, please feel free to message us either through our chat bot on our website, or you can call the hotline and ask our questions. We're here to support you. So thank you all for joining us today. We are at the hour, and we welcome, again, we will host more of these programs in the future. So do look for those, and you'll see posts on social media. So if you're not already following EloQuest Healthcare and Interad Medical, or I should say SecurAcath, on your primary social media channels, Facebook, LinkedIn, etc., we will post when we're hosting more of these programs. But thank you so much, Sasha. Your insights and experience were really awesome to hear, and I greatly appreciate all of the moments that you shared with us. It was fantastic, and great advice, great tips, and excellent hand position. I couldn't have taught it better myself.
Thanks.